Welcome to Quality, where we're exploring quality in emergency care. This is your host, Arjun Venkatesh, and today is our next, and in many ways, probably one of our early episodes in our series on venous thromboembolism. And we've got a special guest. I'm joined by my co-lead of the VTE Collaborative, Dr. John Sather, and importantly, we've got Dr. Jeff Kline, the world-renowned expert in PE and DVT research in emergency medicine. He's the Associate Chair of Research at Wayne State's Department of Emergency Medicine in Detroit, and we're lucky to have him with us today. Jeff, welcome to the show.
Well, thanks for having me. Look forward to the questions.
You know, I think you're one of the few people who can literally say you've witnessed sort of the life course and been such an important part of it when it comes to research and practice change in PE and DVT in the emergency department setting. How do you describe sort of the current state of where we're at? You know, where have we made the biggest progress in these last couple of decades, and where are our biggest gaps now?
Yeah, I just put a lecture together that I gave over in Scotland a week ago, and I sort of sarcastically said, pulmonary embolism, 30 years later, some progress, not that much. The reason I was a little sarcastic about it is certainly we've made progress going from VQ scan to CTPAs. We've got the D-dimer and pretest probability instruments in the ED that we didn't have 30 years ago. And then we have reperfusion methods that are new. But on the other hand, we still don't know the right dose of fibrinolytics for pulmonary embolism. The dose was based on myocardial infarction back when the FDA cleared it for marketing for PE in 1992. We still have lots of people using unfractionated heparin, despite 1A evidence we should be using low molecular weight heparin. And we still have plenty of patients who are not ever tested for PE who die from it. In fact, the mortality rate is actually increased or at least stayed flat, depending on what database you look at in the United States, while in Europe, the mortality rate from pulmonary embolism has decreased over the last 30 years. So it's a little bit of a mixed bag. Some things have improved. Room for improvement exists.
Yeah, Jeff, I'm glad you mentioned that in terms of sort of that bottom line impact of all the work we've done, being sort of the improvement in mortality or lack thereof. We had another podcast, we were kind of talking about where the research has met the bedside and maybe where the research needs to do a better job getting to the bedside, or the research that's not even been done yet that needs to be done to get to the bedside. What do you think the barriers are? Why do you think we've focused on it for 30 years, really advanced the science, have a fairly good understanding about whom to test, whom not to test? I feel like that's reached the bedside. Where are we missing something? What's going on?
Well, still the majority of deaths from pulmonary embolism are recurrent pulmonary emboli. So that asks the question about how long should we be anticoagulating? And why do we do some crazy 3 or 6 months and then stop? And, you know, there are 3 or so stopping rules, the Vienna, the DASH, the HER2. Only one of them uses a biomarker, the HER2. I believe that we should be, with DOACs being as safe as they are, as long as we can get access for all people, DOACs should be given until we have a biomarker that says there's no more clotting going on. And that would save a lot of lives right there. The other area where we really need to make gains is understanding the cognitive processes of physicians that lead to anchoring and framing and the failure to consider a diagnosis of pulmonary embolism, because that's every medical malpractice case I ever see where a patient died was the doc never thought about pulmonary embolism. And understanding those heuristics that mess us up and prevent us from ordering a D-dimer or considering the PERC rule or considering a CT scan.
Let's dig into this diagnostic issue because I think it's really important. You know, last year, the AHRQ diagnosis report came out, caused a mega stir and I think appropriate response from you name it in sort of organized emergency medicine. And to the average doc on the ground, it feels like sometimes we are faced with this impossible challenge, which is to be perfect stewards of resource, perfect about diagnosis. And in many ways, I would say, like, of all the places where we at least have some science to guide some of that, it's PE compared to some of these other things. Like, there is no decision rule to think about epidural abscess. you're also the editor of AEM. I know you guys are doing a bunch of work on diagnosis soon. Like, how does this fit together? Like, how should we think about diagnosis, quality, that sort of thinking in emergency medicine?
Well, I always called it the type 2 penalty paradox. Type 1 error is when you say there is a difference, but there's not. Type 2 is when you say there's no difference, but there is. The type 1 error kind of means you failed to protect the pack. Type 2 errors means you sort of squandered resources. So we weigh type 1 error 10 to 1, 15 to 1, 20 to 1 over type 2 error. You don't ever see an M&M conference where someone is sort of persecuted for ordering 8 CT scans on a shift that were all negative. That's just not how we're geared. The other part of diagnosis is, I think we could learn from the Europeans, because when Europeans make a mistake, they really do look at the system rather than the person. And too much is done with root cause analysis. Everyone knows root cause analysis doesn't solve errors. We have to all solve errors. And there has to be more of a team approach to understanding diagnosis. The CDRs, maybe they're helpful. Maybe there will be, the magical Microsoft paperclip that runs on top of the EMR that can remind us not to discharge patients with a heart rate of 105 without explanation. But I think a culture change where people don't feel penalized in M&M. People don't feel like they made a mistake, like they're ashamed of themselves. That's what I've been wishing we could do since I've been in medicine.
Yeah, Jeff, that's interesting. One of my roles at Yale is as the director of patient safety and quality, and we wrestle with that approach to quality improvement daily. And there's many things you sort of mentioned that get wrapped into that, but changing the culture of feedback provided to a clinician or a system definitely needs to happen, because I agree with you. I think we're in a situation where you hear about a missed PE once in a blue moon when it happens, and when it does, it's usually pinned on the clinician and some cognitive factor, and they miss some clue rather than the system in which they work. And then solutions designed to improve patient safety, particularly with respect to VTE, sort of miss the mark sometimes. How can we change that?
I'm going to go back to what I said about Gestalt processing. There's at least 5 components. We all can have our own sort of view of what gut instinct is, what Blink is about, and all of all that's been written about system 1 thinking. Here's the biggest thing that I try to teach is it's okay to switch horses some percentage of the time. And I think we need to teach residents, it's okay for you to switch horses 10% of the time when things aren't making up. Now, I don't want to work with a resident that switches horses 90% of the time, because we're never going to make a decision. But I think too often that they believe that they can't step back and then employ that system 2 thinking, and they have to go with their first instinct. That's what I see would save lives. That's part of overcoming the framing and the anchoring, which are the most common reasons that the diagnosis of pulmonary embolism is missed. People anchor on dehydration. They frame this is purely GI, and they don't look at the pulse ox of 92% and that the heart rate is not coming down with fluids. Oh yeah, and that the nurse wrote the patient had chest pain, but the doctor didn't write it. These are all things that are downstream from anchoring and framing, and teaching that it's okay to change horses sometimes. And I hope you know what I mean by the metaphor, change horses, to switch your diagnosis. That could save lives. Now, the turnaround time, the length of stay, all the metrics we're looking at are against that, because I just had my review this morning, and I get dinged if I, have a turnaround time or time to disposition that's, worse than average.
Let me ask you this, because, recognizing the challenge around diagnosis, it feels like there's an era of the era where you got the Wells score, and then you had the PERC rule, and we developed all these clinical decision rules to try to standardize in some way some of that clinical decision making, with the hope that if it was more standardized and more structured, that people would make more consistent, they would approach diagnosis more consistently. All that got developed, though, in an era when at best you had these ED information systems that would track where somebody was on a board. You didn't have EHR data. You certainly didn't have the wealth of sort of big data analytics that we have now, let alone some of the new AI tools. If you had to, this is a thought experiment for you now, Jeff. if you were starting your endeavor to improve diagnosis for PE, but it was with today's technologies and today's digital tools, how different would you do it?
Well, we're getting what we need from legislators finally. And first of all, we need money. There is the Charles Rochester bill, which I think some of you know about. It's a $100 million appropriation that's got bipartisan support on Capitol Hill by Lisa Blunt Rochester in memory of her husband who died of a pulmonary embolism. We have a surveillance network that's getting stood up in Florida. That's now a law there. So it's the answer to me is a PE, VTE specific surveillance network that doesn't just look at diagnosis. It is able to look at imaging for PE and then retrospectively look back at what has happened within healthcare exchanges over the previous month or so. So, again, thought experiment, patient comes in, gets diagnosed with a pulmonary embolism, but was seen for an upper respiratory infection 2 weeks earlier. And when we look back on it, boy, there's a lot of vital signs, and look to this chart that was highly likely to have been a miss, and or at least associated with a miss. And then, had that PE not got diagnosed, the patient might have went on to die and been a medical malpractice suit. So I just see surveillance networks, with deep data, not just big, broad data, but deep data, being able to solve the problem of what is a missed PE and how do we not miss it?
Yeah, I was going to ask you sort of that question. It seems to me that we have the technology. It may not be refined quite yet, and it sounds now like you're mentioning finally some of the capital behind designed to fund some of this surveillance. But it seems to me like we ought to be able to build essentially or understand a phenotype of a typical missed PE. You mentioned a lot of the physiologic derangements, some chest pain that got mentioned in a nursing note, but the doc didn't enter it, or the heart rate despite a liter or two of fluid that's still elevated, yet the patient gets discharged. I almost see a situation where we understand enough about what a missed PE looks like that in real time, as you're about to click discharge, something says, the overarching AI says, hey, are you sure it's not a PE? And then conversely, we've talked a lot about the other side. Hey, you sure you want to order that CT? This patient really seems like they're exceedingly low risk. Do you think we're going to get to that point? And do you think clinicians will be receptive to that?
Well, we're going to get there whether we like it or not, and clinicians are not going to like it based on interviews and work that Lauren Westifer has done and Kirsten DeWitt have done talking to doctors. And I'm going to exaggerate a little bit, but their work shows that doctors resent and maybe even kind of hate CDRs trying to tell them how to practice, and they see it as an insult, and it makes them mad. So that's part of the whole thing of the culture is this thing is here to help. By the way, I made a little old guy joke. I don't know if you guys remember the Microsoft paperclip from Windows 2000.
Oh yeah, it
And
used to have a name.
Yeah, it's the thing we'd always jump up on, everyone hated it. And it actually was a little bit of an early progenitor to AI. But, the docs really have problems with the CDRs. And, but they really are seen as a potential solution. Let me say one thing. If we're going to train a machine, we also have some simple stuff we're sort of leaving on the table, one of which is just the ECG. And if you look at fatal PEs that die in the hospital shortly after being in the ED or go home and die shortly later, many of them have acute pulmonary hypertension on their ECG, and none of the machines, none of the computer reads pick it up. So I've tried to work with Marquette. I've tried to work with Harry Selkler and others that have done things like this. I just wish we could get that read on there. This is a pattern, and it's not chronic pulmonary hypertension. Acute pulmonary hypertension looks different. And, if it could read it and say acute pulmonary hypertension, consider pulmonary embolism, that right there, my rough guess, saves hundreds of lives across the United States.
That's an interesting one because I know, there's a cardiologist here who recently got an FDA approval for taking just same EKGs that we're doing on everybody, was able to diagnose a pretty rare form of structural heart disease because, you know, the machine is going to be able to detect signals. It can deal with a messy baseline. It can, you know, accommodate all kinds of information from that EKG that we just as humans can't do, even with all the training in the world. And that's a wonderful example because it's data that's just sitting right there right now.
Right.
Yeah.
Yeah. I mean, it's there. It's ubiquitous. There's information, and that's simple solution. Looking at the more complex machine learning models, you know, we don't know what we don't know. You know, do PEs present more in the morning? Do they present on Mondays? Do they present when there's high pollution levels that can be monitored by EPA devices that are all across the United States? I'm spitballing these things for people to think about. There are a lot of stuff that we don't know about that the machine may find that could be put in a model that helps with, you know, the prompt of just be thoughtful before you discharge.
I want to go back to something you mentioned earlier, which is sort of, you know, the how have we not even gotten better about anticoagulation? One of the things that it feels like in emergency medicine is we have really been keyed in on and thinking a lot about diagnosis. Did we miss a PE? But disproportionately have not spent nearly as much sort of time, education. You don't see it, right? At the meetings. You don't like even when somebody gives a PE talk to our residents, 45 minutes of the hour is on pretest probability and diagnosis. And then there's like something squeaked in when it comes to treatment. But a lot has sort of changed and evolved there. Do you think we just haven't given it the attention? Or is it that there was a lag and that the science is just now better than it was before?
I think it's completely the former, is that we don't have emergency physicians who are out behaving like experts. And it's kind of, I said it that way on purpose, because a lot of the anticoagulation people are being paid and, you know, they're using slide decks that industry is giving them. We need to understand, like, for example, the following statement is not true. You cannot just stop unfractionated heparin, and it is not more reversible than low molecular weight heparin. Protamine works for both. And most emergency physicians believe this fallacy that unfractionated heparin somehow can be stopped and the bleeding will stop. Well, you know what will prevent bleeding is stopping it in the first place, because it's lower with low molecular weight heparin. That's just one thing I hear emergency physicians say all the time. And also this normative behavior of, well, you know, my hospitalist wants unfractionated heparin, or the intensive care unit will want unfractionated heparin. But any expert will tell you that that's a wrong decision. I think I should be taken out of the Pyxis myself. That's just one part of treatment that you're talking about. And of course, there's a lot more to go with DOACs and, you know, understanding adherence and access to these DOACs. I'm talking about economic access.
It's interesting because you talk about it with like, I really love it with pride, right? There's this pride that as emergency physicians, we're not just tasked with trying to make this tough diagnosis, but we really do dictate the treatment cascade. And sort of, you know, what's your take on like all the stuff that's going on with thrombectomy, interventional therapies? You know, like, is that like, should we be speaking with force there?
Well, yes. And I am, you know, I'm a strong advocate of the PERT consortium. It was started, in my opinion, by an emergency physician, Chris Cabral. I hope you'll have him on your show soon.
He's on the next episode. Yeah.
Yeah, he's a great friend. He's a brother of mine, not a real brother, but you know what I mean. And you know, we are working toward developing an emergency medicine consortium that represents at the PERT meetings, because right now it's all industry dominant. And that's all downstream from the DRG that you get for doing a thrombectomy, which is, you know, a big DRG, and it's all being driven by profit motive. Now, yeah, we have 2 randomized trials, Ultima and Canary, that showed improvements in echo parameters at 24, 48, maybe 72 hours short term. And those closed the gap at 3 months, the Canary study showed. These are all being done because of the appearance that we're doing good, rather than an actual trial that shows a functional or survival outcome. Now, hats off to Aki Sista, who has funding for the PE track trial, which will help solve this problem. But either if he gets it done, the results of that are going to be 7 or 8 years from now.
So Jeff, as we've sort of talked about the fundamental problem, which is minimal impact over all the years on mortality, which I think really is what we care about. I think related to that is cost and resource utilization. We've kind of highlighted, I think, three aspects. One you mentioned earlier on, which was inappropriate duration of anticoagulation as an outpatient for patients who have been diagnosed with a PE. You mentioned sort of just the classic misdiagnosis, failure to consider, failure to change horses or work up the diagnosis when the clinical parameters don't behave the way you believe. And then we kind of touched upon the treatment of what we'd call high risk or intermediate high risk with thrombectomy initiatives and management strategies. Of those three, which do you think, where's the most bang for the buck?
Oh boy, I wouldn't want to pick between my children, you know, they all matter. Let me just say the one that comes to mind, and that is the reperfusion therapy. I personally have been trying to take this back and trying to get a dose finding trial funded by NIH. I can't get the score I need to do this study. Look, catheters are not going to be available and I'm going to say a number and people aren't going to like it, but these thrombectomy catheters are not going to be available in 90% of hospitals, 90% of emergency departments across the United States. And where's the disparity the worst? It's in rural settings. And if you look at the mortality rate in the rural settings, it's driving part of that increase in mortality because patients are not getting any reperfusion in that setting. The only thing that's going to happen there, at least in 2024, is enzymatic reperfusion. You can't transfer everybody to the big house. A lot of patients don't want to be transferred. They want to be treated at home, even in critical access hospitals. So that one's kind of near and dear to my heart, John. I think that's my answer out of the three if I had to pick among all the children I love equally. But right now, that's my favorite.
I'm surprised we got an answer out of you on that one. So that tells you how important it is.
Yeah, it's also personal. I'm from Appalachia. I'm from a rural area. And if you look at the work that's like Carlos Camargo and others are doing, the disparity in emergency care and the need for good care is, I think the rural disparity is the biggest we have right now in emergency care.
Well, I'll tell you, for our listeners here on Equal, part of the Equal network, 30% of the EDs that tend to join the Equal network are located in rural or critical access hospitals. And so it has always been our goal to sort of think about how we develop tools, how we disseminate content that's not designed to work at Wayne State or Yale or anything like that, but rather for the actual kinds of EDs where most people in America actually get their emergency care, and where you're right, the VAT, like many of these things are not going to be available. We just looked at data this morning. We asked around the Equal EDs how many have access to formal echo, and half of them have no chance of having formal echo access. That's not going to change. They're not going to all of a sudden have an echo tech on board, even if you can get a telemedicine read at hundreds, if not thousands of EDs around America, because there's just never going to be a business case and ROI around it. And so we're going to have to think differently and do disruptive stuff if we want to get to them.
But, combining that phrase disruptive stuff, Arjun, you mentioned, and then Jeff, you mentioned sort of maybe what's going to be needed is for emergency medicine as a specialty to sort of be the champions of pushing some of this science forward. The challenges you mentioned in the rural settings to achieve reperfusion, I'm not so sure they don't apply to academic centers, urban centers.
Yeah.
We have a PERT team at our institution. It's wonderful and it's robust. Yet more and more we activate, it seems, the PERT team, and then a bunch of cooks come in the kitchen, and no one can really make a decision. And I kind of hear you when you say maybe we should be making this decision. And I think we either don't have the ability to achieve mechanical thrombectomy in a rural setting, or we don't have the ability to sort of override those that say, yeah, we're thinking about doing it, so no enzymatic reperfusion right now, and then hours go by, days go by, and I feel like we lose the ability to intervene. So I think it's a huge challenge in all settings.
Well, just one brief comment that the PERT team, it sort of puts together and kind of allegedly unifies a decision. So somehow a decision is made that seems to be a collaborative. But that does take away from the craft industry, which we don't have any evidence that it's better than the craft industry of having one person make the decision. I oftentimes think it's sort of remiss when the pulmonologist and the other members of the PERT team come down and they don't talk to the original emergency physician who happens to know the patient fell and hit his head or her head as part of the history. And sometimes we also know things about their cancer that nobody else knows. The only bleeds that I've seen happen from catheter thrombolysis was when the patient was taken for CDT. Now, this is not aspiration catheters. This was when we were doing the ECOS and the bland catheter infusions, was patients that had metastatic cancer, but the person that was doing the procedure did not know the patient had metastatic cancer. The ER doc did know, and the information did not get communicated. So that's a kind of an example of what you're talking about there, that we matter.
Well, and I think it's a wonderful example, and it is the basis by which you go back to all the work that happened with door to balloon time in the 2000s and the large ACC collaboratives. And when the primary recommendations came out, both from the quantitative and qualitative research, one of the most critical quality improvement interventions was emergency physician activation of the cath lab, because we had all the information, we knew, and we mattered. And in some ways, I think that there is a similar parallel construct around sort of our ability to own and drive care here too.
Right. I will go back to the three children that John posed me with and say that I think more lives are lost by delayed or misdiagnosis than are lost by, getting them to the cath lab fast. And also young lives, because a lot of times it's these atypical presentations from young people that had, 70 years of life ahead of them. And, that brings us back to the idea of understanding what an atypical presentation looks like and perhaps having assistance in recognizing that.
That's a useful lesson, Jeff. Thank you. I want to thank you for being on today. This was an awesome whirlwind of, I feel like, all things PE, DVT. We talked about diagnosis. We talked about treatment. We talked about the history of it. I think you gave us wonderful perspective on where the gaps are and where the opportunities are. And this is a real great kickoff to our collaborative. We have a bunch of great future episodes with other national, international experts around VTE. We're going to be talking around and really digging into a lot of the things you set us up with today. So thank you for being on, and hopefully we'll have you back in the future.
Great. Thanks a lot.
Great talking to you, Jeff. Thank you.
Take care. Bye now.